Darren. Darren has been part of this journey since the very beginning, and it's an absolute pleasure today to introduce our opening keynote speaker, Wes Streeting MP. He is, for those that don't know, he's the Shadow Minister for Healthcare across the United Kingdom. He's also my parents' local MP, so it's an absolute pleasure to introduce Wes to the stage so that he can talk about health inequalities and all the wonderful work that he is doing around that. So let's everyone introduce Wes to the stage. Thank you.
Thanks, Miranda. Thank you for inviting me to be here this afternoon to talk to you about health inequalities. And it's great to be here to celebrate what I think is the 8th year of this foundation, doing work that's very close to my heart. I grew up not too far from here in the London Borough of Tower Hamlets, in Stepney, in East London. Unfortunately, I'm still broadly unrepresentative of the House of Commons, which is even more unrepresentative of the country, but we're working on it and trying to make sure that in positions of leadership and power and influence in our country that we have people who look like the country over which power and decisions are exercised and made, which is something very close to my heart, and I will talk about that in the context of health and social care. And thank you to Hogan Lovells, our wonderful host, for this excellent view. A lot better than the view in my office, that's for sure. So it's great to be out of Westminster, just up the road. Look, I'll set health inequalities in a broader context to begin with, which is what is objectively the worst crisis in the history of the National Health Service, whether we look at record high waiting lists now approaching 8 million, whether we look at the everyday struggles that people have to book a GP appointment or to see a dentist, whether I think it's probably the unprecedented situation in the history of the NHS, which is people no longer being absolutely confident if they dial 999 or arrive in A&E that they'll be seen on time. It's fair to say that as we mark this, the 75th year of the NHS, its 75th anniversary, it's never been in a poorer state. And as waiting lists rise, public confidence falls, and people begin to wonder whether or not we will even be able to have or afford a national health service that's publicly funded, a public service free at the point of use anymore. And last week at Labour's conference in Liverpool, I set that anxiety of the public against what I think is a genuine existential crisis for the future of the NHS, actually, which is, it's not just about the immediate crisis in front of us of record waiting lists, it's about the medium to longer term existential challenge of a growing ageing society and also rising chronic disease. And if you map those two things together, our health system begins to look very much in jeopardy. I think it is an existential crisis, but it is one we can avoid. So my remarks to you today are actually founded on optimism that the National Health Service that we've had for the last 75 years, a public service, publicly funded, free at the point of use, can continue to be there for us for the next 75 years and beyond as a public service, publicly funded, free at the point of use, if we make the right decisions now about the way in which the NHS needs to change. Because when I've looked at other healthcare systems across the world, particularly among some of the advanced economies and countries that get far better and more equal outcomes compared to our system, the conclusion I've drawn is a very simple one. We've got an NHS that gets to people far too late. So we end up with late stage diagnosis and treatment in our acute hospitals. Worse for patients, because the later we reach people, the harder it is to treat many conditions. Also more expensive for the taxpayer, because often if you take a condition like cancer, for example, if you reach someone in late stage, stage 3, stage 4, not only are the outcomes likely to be worse, the journey that patients have to go through, the struggle that patients have to go through is much worse for them, also much more expensive for us to deliver. So there are 3 big shifts we need in our healthcare system. We need a shift from that late stage hospital treatment I described to earlier intervention. That means shifting the focus out of our hospitals into primary care and community services, making it easier for people to see a GP, cutting some of the red tape that holds GPs back so they can focus on the thing they really value, which is building a relationship with their patients, providing that continuity of care that means that people once again feel like they have a family doctor, I think, which is a sort of very distant memory for lots of people in our country, but one we've got to restore. Making sure that we've got people in a range of services that are helping to ease pressure on some of our GPs who are struggling to cope with demand. Community pharmacy, for example, can play a really big role. Those people in white coats behind the counter, they're not just there because they're really good at counting pills and making sure that the prescription in one hand matches the prescription, the medication in the other. They are qualified medical professionals in their own right, and actually very well qualified if we get them working at the top of their license and doing the things they do best to give really good health advice, to do some diagnosis, to do some prescribing of their own. That would be a big difference for patients and also ease some of the pressure on GPs. We also need to create some new services. One of the things that I'm really anxious about in our country at the moment is the mental health crisis, and in particular the way it's impacting on young people, both in terms of the long-term tail effects of the pandemic, which not only caused enormous disruption to young people's education, but I think had a really big impact on young people's well-being, which we've still yet to fully recover from. Also, I think, pandemic aside, young people growing up in our country today face a whole load of pressures that, frankly, my generation didn't. I know I look very young, and you think, no, you must surely have grown up with this social media age. No, I'm actually now about to enter my early 40s as I cross over from 40 to 41 in January. I know, I can see the jaws dropping. I can give you my skincare regime later. But there's, I think when I certainly talk to young people in schools in my community, I'm really conscious of how much of a weight they're bearing on their young shoulders. And I think particularly in an age of social media, that means that people carry home with them some of the bullying and stuff that I used to be able to leave at the school gates. It now follows them at home and often into their own bedrooms on their mobile phones. People turn on social media, which is a brilliant thing in terms of remaining connected and learning new things and finding out new things and being creative. There's so many benefits, but also loads of pressure, whether that's on things like body image or the risk of online grooming and some of the other harms that we see perpetrated online. And I think we owe it to this generation of young people not just to ensure their education recovery from the pandemic, but also to ensure their well-being recovery. And so for us that means dedicated mental health support in every school and community mental health hubs in every community, because if we can get to people much earlier in terms of their mental health, then that, going back to my point about early intervention, means that their health outcomes are likely to be so much better. So that's the first big shift from hospital to primary and community services. The second one is a shift from a very analogue health service. Doesn't really work in the way that technology enables most of the rest of our lives. Talk to members of NHS staff, they'll tell you technology is great, it improves every part of their life until they walk through the front door of their workplace, and they're just grateful if the monitor turns on, if it doesn't freeze up in front of the patient in front of them, as they open multiple applications to deal with the same patient. So, and that's before we get to the really groundbreaking, game-changing role that artificial intelligence, machine learning, genomics can have in terms of the future of medicine, the future of healthcare. Not just doing that earlier diagnosis that I mentioned earlier, but actually doing prediction and prevention, preventing people from becoming ill in the first place. And the third big shift we need to see is from an NHS that's very much a national sickness service to one that is a genuine health service, not just treating sickness, but preventing it. And so prevention is really important. And in every single one of those areas, there is a real inequalities lens. And I say inequalities lens rather than equalities lens deliberately, because I think even the NHS at its best over recent decades has still been one that hasn't been best for everyone. And I think of the many things that the pandemic taught us about our society, if we didn't already know those facts already, one of the things that I think was shown up most starkly was the different impact of the pandemic on different communities, and thinking about the NHS in particular, despite having an anniversary that it shares with the arrival of the Empire Windrush. Not just a random coincidence, by the way. You think about the history of the NHS, it's literally built by and with and for the Windrush generation. You know, despite that diversity being built into the NHS from its very foundations, we still see a National Health Service that doesn't treat people equally, that doesn't reach people equally, whether that's in terms of the care that it provides to patients or indeed the way that it treats even its own staff. And so, you know, whether it was the fact that when it came to the vaccine rollout, the NHS did really good, really quickly, reaching lots of people, up to a point at which it realised it didn't have deep and meaningful relationships with certain faith communities or certain ethnic communities, suddenly had to turn to partners, build new relationships. It told us that actually for lots of people in our country, the NHS doesn't reach everyone equally. Or the fact that we see through some of the data that we already make good use of, that black women are 4 times more likely to die whilst pregnant or giving birth or as new mothers than white women, or whether it's the fact that we still see through the data the disproportionate experience of bullying and harassment in the workplace by black staff. You know, we've got to be honest about the shortcomings of the NHS if we're going to make it the best national health service that it can be, and able to serve all communities equally. And that's something that is very close to my heart. And of course, the NHS doesn't exist in a vacuum. It is a reflection of our society and the deep inequalities within it. And we're conscious of the fact that the only way in which you narrow the gap in health outcomes between rich and poor, black and white, you know, women and men, is to deal with some of the underlying inequalities in our society, what in health policy jargon is often called the social determinants of ill health. Michael Marmot has been one of our best voices and leaders on this, not just domestically in our own country, but internationally. I mean, some of the statistics on this are really quite shocking. A girl born today in the most deprived 10% of local areas is expected to live 19 fewer years in good health than a girl born in the least deprived. Even in this city, which, let me tell you, when I'm going around the country as Shadow Health Secretary and people ask me where I'm an MP from, I always say Ilford in Essex, because although I'm a Greater London MP, everyone outside London hates London. You would think that when I talk to people from around the country that the streets of London are paved with gold and we get everything in this city. Well, it is true, unfortunately, that power, wealth and opportunity and investment are disproportionately concentrated in London and the South East. But I think I'll be preaching to the choir in this room, but take it from you know, a working class kid from a council estate in East London, we know just how deeply unequal this city is. So unequal that when I'm travelling home from Westminster in the evening and getting the Jubilee line out to Stratford before I get the Central line onto where I live in my constituency, life expectancy drops by a year for each station on the Jubilee line travelling east from Westminster, by a year for every single stop on the Jubilee line in this, one of the richest cities in the world, in fact the richest city in one of the richest countries in the world. And we've also seen some really startling stories in the news about the direct impact the conditions in which people live have directly on their health and their life chances. Whether it's the appalling cases of children being admitted to hospital or even dying because of damp and mould in their homes, often not their own homes, but the temporary accommodation they're placed in by local authorities. The estimated cost to the NHS of treating those affected by poor housing has been placed at £1.4 billion a year. I think for me that's the real kicker. Not only are people having a miserable experience impacting on their health and their opportunities in life, we're paying through the nose for that failure. It doesn't make any sense. It's a waste of money, of course, but even more importantly, it's a waste of people's lives and potential. Look at air quality in this city and across the UK. human-made air pollution in the UK causes between 28,000 and 36,000 deaths every year. The total cost of that to our NHS and social care system is placed at £1.6 billion between 2017 and 2025. And I think for the Labour Party, and thinking about what we might do if we are in the privileged position of being able to form the next government, which we do not take for granted, not a single vote has been cast, we've got to earn every single bit of support that we get. The approach we've chosen to take is what Keir Starmer calls a mission-driven approach, because turning around this situation I've described, the worst crisis in the history of the NHS, the deep inequalities that hold our country back, that requires people to pull together. It requires people to pull together across government. So every government department sees it as part of its job, part of its mission, part of its job, part of its mission to tackle these deep health inequalities and challenges, to promote good health, but also recognising that not only can the Department of Health not do this on its own, or the NHS not do it on its own, the government can't do this on its own either. If we're serious about tackling some of these inequalities that hold our society back, if we're serious about promoting good health and positive well-being, so that we're not just living longer but living well for longer, government has to work in partnership with business, with civil society, and with all of us as individual citizens, really being empowered to take control of our own health, really feeling like we have a say and a stake over our futures, making sure that we don't have the stress that comes with a lack of money, making sure that we can not only make ends meet and pay the bills, but do the things that make life worth living. I think the sadness I feel about our country today is that it's not just people at the sharpest end who are having a really hard time. Important though that is, you would expect me to say, both in terms of my own background and as a Labour politician, it's the fact that people who consider themselves to actually have decent jobs and have a mortgage, who are now thinking, I'm not sure we can afford that family meal out. How do we tell the kids we can't go on holiday this year? And being in the supermarket and thinking, actually, I'm going to have to put this item back on the shelf. And these are people who are on relatively decent incomes, let alone people who are finding things so tough that there are now more food banks in this country than there are McDonald's. So in order to make sure we're able to do this, there are lots of ideas that we have. For example, if we have the Department for Education providing a free breakfast club in every primary school, and access to sport through the curriculum consistently in every school, well, that's brilliant. Kids start the day with hungry minds, not hungry bellies, and they're taking up pursuits that hopefully they'll continue into adult life, which makes it less likely that they will fall ill and end up with some of those entirely preventable diseases like heart disease or diabetes. If we retrofit 19 million homes and bring in a legally binding decent home standard to end impunity for irresponsible landlords, then people have a decent home to call their own. They're less likely to be ill and less likely to end up coming through the front door of the NHS. If we have a Clean Air Act with stricter statutory targets on air pollution that match World Health Organisation's recommendations, then everyone in every part of the country will be able to breathe clean air. If we reform universal credit and make health-related benefits more flexible so it's easier to get people back to work, well then that's better for them and better for the taxpayer and provides a genuine welfare safety net rather than the one we see today, which is full of gaping holes. If we improve people's rights at work and work with employers, then people will be far happier, more motivated at work and are less likely to fall ill. And if we get this right, then we can end some of the deep injustices in our society. It should just not be the case in 21st century Britain that black women die in childbirth disproportionately compared to white women. If we have more midwives, we train them more effectively and educate them on how to work with diverse patients from a range of communities, then we can end some of these deep injustices. It requires leadership, political leadership, sure, but it requires leadership right across society. But one of the reasons I came into politics was to tackle some of the inequalities and injustices that have impacted on my family, But more than that, I want to tackle the inequalities and injustices that affect families right across our country. In doing that, we create a more fairer, more equal, more just society for everyone, and create a future for our country and our wider world in which whoever you are, whatever your background, whatever family you're born into, whatever circumstances you're born into, you have the same choices, the same chances, the same security, the same opportunities in life that we would want for ourselves and hopefully everyone else. That future is possible. It might feel hard sometimes. It is hard, and it should be hard, building that kind of society, but it's because it's hard that we need to apply our minds to it even greater, and that is the challenge that gets me out of bed in the morning, and one I've been delighted to talk to you about today. So thank you very much for having me. Now, we've got some time for questions before I have to go back to Parliament, to the Parliamentary Labour Party meeting with Keir Starmer. Yeah, one right at the back there.
Hi, thanks very much, Wes. I'm Dr. Chris Gondam from King's College Hospital, and it's great that we really touched on some of the things that I think most of us here are very concerned about. I know you talked about the inequality in terms of looking at health lens, but I think the biggest issue that we find within the NHS is the fact that we do not have leaders who obviously look like me, sitting on those tables, they will say, what are the priorities, particularly for our communities now? If you come in, I hope you do come into power and then say, so what are you going to do to address to ensure that all our, particularly our executive boards within the NHS, really truly reflect people like me to be decision makers in order to address some of those inequalities?
Yeah, it's a really great question, and again it goes back to what I said at the outset. If you think about the diversity of the NHS workforce throughout its 75-year history, it's pretty criminal actually. We've reached a situation today where there are so few leaders from black and other ethnic minority communities within the National Health Service itself. And I think in terms of dealing with that, we've got to think about training, progression, and also how to break open some of the professions which frankly are still, if you think about some of our medical schools, they are still largely dominated by the sons and daughters of doctors and consultants and senior leaders in the NHS. And you know, I think it's wonderful that people feel inspired to follow in their parents' footsteps. When it comes to fair access and widening participation, you know, I'm always at pains to point out, and I've been doing this since I first arrived at Cambridge University and had to reassure my privately educated friends that we weren't trying to steal their future just by, you know, being as good and having equal chances. But, you know, there is a real problem here in terms of the talent pipeline from that point, and then thinking about the coaching, the leadership training, the mentoring to bring leaders through. And, you know, I sort of have mixed feelings about this sometimes because we give almost two contradictory messages on diversity and leadership. On one hand, we say you can't be what you can't see. I mean, I prefer to sort of flip it on its head and say you've got to be the change you want to see as well. So I think we've got to look at those people that aren't breaking through into the echelons of senior management, ask why that is, who are our emerging leaders, how do we give them the training, support, the coaching, the mentoring to break through? Because one of the things that I'm conscious of is that whether it's politics, whether it's the media, whether it's law, whether it's public services, so much of your career progression is about the professional networks you build, about the learning you do from your peers, and it is partly, I'm afraid, an unfortunate trait of human nature that we do tend to kind of find people like us, whoever that might be. I sort of did it when I first arrived at university, sort of found all the state school kids, and then eventually realised I need to get over some of my own prejudices and preconceptions about people from other backgrounds and become some of my best friends. But I think those are the sorts of things we need to look at. We can do some of that through systems and processes and training. We've also got to change the culture, and for me, that's one of the hardest challenges I'm thinking about in the NHS at the moment in terms of things like patient safety, some of the awful cases we've seen in the media. Sure, we can do things like forms and reference checks and so on. We can use data in a smarter way, sure, and that particularly applies to diversity, but this is also about culture and an institutional culture that holds diverse leaders, potential diverse leaders back. We've got to change that culture. Yeah.
Mr. Streeting, thank you so much for your speech. My name is Carla, I'm a first year NHS is the denial of women and the denial of our own healthcare in regards to our own issues, especially menstrual issues as well. I know my experiences with the NHS haven't been very pleasant, especially being a woman, and I think it's a stigma built within the foundations of the NHS to perceive female issues as they're being dramatic, or they're over-exaggerating the issue when we ourselves know that it's a very prevalent issue. So how do you think the NHS can go about breaking down that stigma, since it's been in existence for decades, and I think it's time we need to change that?
Yeah, I think that's a great question, and one that is very close to my heart. I've got family members that have had similar experiences to the ones you've alluded to, and I've talked about maternity. How is it that it takes around 7.5 years to get an endometriosis diagnosis? Please don't tell me if this was a condition that affected men, we'd be waiting 7.5 years. Appreciate it's not an easy condition to diagnose, it's a process of elimination, and part of the reason it's taking so long is because just getting back through the door again and again takes time. But 7.5 years, sorry, that tells me that women aren't seen as equal and taken seriously enough. Polycystic ovary syndrome, another really common condition. Friend of mine, her daughter was told to take the pill, suffered hair loss, weight gain, huge impact on her self-esteem. Her mental health began to suffer and left lethargic, really miserable experience. Paid to go private, see a private GP, got prescribed a different drug, which has been a game changer in terms of her experience. Hair loss has stopped, weight gains reversed, and she's leading a really happy life. The tragedy is her best friend's in the same boat, can't afford the private GP, and is going through the same thing that she's gone through. There is a women's health strategy from the government. There's quite a lot of good stuff in there, it's just not happening consistently. We're looking at how we can update and improve it. And also going back to what I was saying about mental health services, whether we can create some new front doors into the NHS through women's health clinics in communities, so that if people feel that they are going to the GP and going around in circles, that women can kind of go, actually, I'm going to go and see a specialist at the health clinic who's used to seeing some of these conditions and getting me the answers I need. Because yes, it's I've spoke a lot about health inequalities, and in particular the way in which they impact on people who are in minorities, whether ethnic minorities or working class minorities. But in this case, we're talking about the majority of the population that are not being given the care and support they need, and we're determined to tackle it. Yeah.
Thank you for your talk. I'm a current master's student studying dementia at UCL, and I'm also the founder of the Dominican Dementia Foundation. So my question to you is, how are you tackling dementia in hospitals, so hospitalization? As you know, every 3 seconds someone gets dementia, and I'm very passionate about this area, so I'd like to know, how is it being addressed, and what is your vision for dementia care in the national health system here? Thank you.
Yeah, I think the first thing we've got to do is improve our research and understanding around dementia. I think the government have made some big commitments in that area, and we're sort of trying to sort of hold them to it, because this is a long game on dementia research, and I'd like the UK to kind of lead the way in better understanding dementia. I think some of the things that have been done by Alzheimer's Society, for example, around dementia friends can make a real difference, because so much of the challenges that people with dementia or families and carers face is a lack of awareness and understanding, and how to provide kind of appropriate supports. I think we could look to see what we can do more in terms of those schemes. It also directly ties into an area which I haven't addressed so much this afternoon, but it's very much at the heart of what I want to do if we win the general election, which is around social care as well. Hopefully care that enables people to live independent lives in their own homes, but if they're unable to do that, that provides really good quality residential care and supported living for people for as long as possible, keeping them in their homes, but providing that route otherwise. This is an area where we continue to sort of push the boundaries of our understanding in terms of knowledge and science. I'd like us to be able to provide more effective treatments for dementia, so that when people receive that diagnosis, they see light at the end of the tunnel, not just a sort of deterioration for them and for their families. Yeah.
question to you is, will we be holding, or will we be able to hold anyone accountable for how the NHS has been treated over the last few years?
Well, firstly, I'm so sorry for your loss, which I'm afraid does underline the consequence of what happens when we don't have an NHS that's there for us when we need it. And last week in Liverpool, one of my constituents spoke on the platform with stage 4 cancer, which is a death sentence. I mean, he will not be alive in 5 years' time, and that was his stark message to the Labour Party conference. And it would have been so different if he'd been diagnosed faster and got onto a treatment pathway faster. So I think that's why the NHS holds such a special place in our hearts. It's in part because of its values that it's been built on, you know, values of fairness and equity. You know, the one thing when I went through kidney cancer a couple of years ago, one thing I didn't have to worry about was the bill, and I think that's wonderful. We've all got experience of the NHS being there for us, you know, from the moment we're born. But I think, you know, that's the paradox of where we are as a society. On one hand, we love the NHS, we believe in the NHS. You know, it is, you know, I say this with some sadness as an Anglican, part of the established Church of England for our country, but the NHS is more of an established national religion in our country than even the Church of England. I hope Archbishop of Canterbury won't mind me saying that. And yet, on the other hand, we can see it's never been in such jeopardy. I mean, I think the COVID inquiry is really important, because I think it is asking some really deep and fundamental questions about the road that led us into the pandemic, and the fact that I think is undeniable, which is people were more dangerously exposed to the pandemic than we would otherwise have been if the NHS had been in a stronger shape and if social care hadn't been neglected by successive governments. So, you know, I was asked last week in Liverpool, you know, we've got to learn lessons from the pandemic and do it quickly. Where does the accountability fit? Shouldn't we just, you know, Boris Johnson's gone, should we just move on from that bit? And I said, look, no, actually, look, for bereaved families, accountability is really important. And I think having us as political leaders accountable is really, really important. Health service leaders, really important. But also, we have got to learn the wider and deeper lessons about, you know, what happens when you run down your healthcare system and don't heed the warnings of the people who are working in it. And I'm afraid that for me is the tragedy of the whole thing, is that it didn't need to be like this. 13 years ago we had the shortest waiting times and the highest patient satisfaction in history. That's possible, we can do it again. The irony is we're probably going to end up paying a heavier price in every sense, particularly the impact on our health and lives lost, trying to get back to that than we would have done if we just made the right decisions in the first place and thought long term about how you get the NHS and our health and care system onto a better path. So that's the challenge that's sort of resting on our shoulders now. It's why I take this job very seriously. It's why I was delighted not to have been reshuffled at the last Labour reshuffle. Because, you know, this, you know, if I only ever achieve one thing in the rest of my life, and it's to mobilise the whole system to make sure we take the NHS from its worst crisis in history to being not just back on its feet but fit for the future, I will die happy. It's the only thing I ever achieve. The thing I am conscious of is that I can't do it on my own. There is not one politician sat behind one desk in one department that's capable of doing this. It's a whole team effort. So we've got to have a really clear national mission, we've got to mobilise a system behind it, and we've got to see this as a big mission for our whole society. You know, government, businesses, civil society, us as individual citizens working together. And if we do that, and if we make the big shifts I've talked about, particularly last week in Liverpool and this afternoon here, then there is absolutely no reason why the NHS can't be the envy of the world. And if you marry the huge sense of purpose and pride our healthcare workers and leaders have in their work with the scientific ingenuity of the people making groundbreaking discoveries in life sciences and technology right here in Britain, then the sky is the limit in terms of what we can achieve. And it's so important at the moment in this period and this culture and this backdrop we have in our country to give people not just the hard-headed realism of how bad things are today, but some hope of a better future, because that's in short supply in our politics and one of many, many, many other problems that we are trying to solve at the moment. then that's why I've got to get back to Parliament. So thank you very much for having me. And thanks.